The title of this article is Comprehensive Clinical Evaluation of FAI, Part 3, Magnetic Resonance Imaging, and it is the final article in a three-part series on evaluation of the patient with hip FAI. Part 1 addressed the physical examination, and Part 2 addressed radiograph interpretation. The authors report the following disclosures. Multiple search patterns may be employed for comprehensive evaluation of hip MRIs. An example search pattern is described here with three distinct layers, including the osteochondral, inert, and contractile layers. The osteochondral layer includes the cartilage of the femoral head and acetabulum. Also included within the osteochondral layer is the key bony anatomy of the hip, specifically the femoral head and acetabulum, as well as any associated pathology. The inert layer includes both the capsule and labrum. The muscular layer consists of muscles crossing the hip joint, including but not limited to the rectus femoris, iliopsoas, hamstrings, and gluteus medius. The typical cam deformity is due to an abnormality at the anterior superior femoral head and neck junction. It may be identified on the done lateral radiograph, although this only allows a two-dimensional representation of the deformity. An axial oblique MRI allows assessment of the deformity at multiple positions along the region of pathology. An example of a cam deformity is shown in this done lateral radiograph. The cam deformity is demonstrated on the axial oblique MRI in the same patient for comparison. Subchondral cysts may be identified in the femoral head or acetabulum, and adjacent bone marrow edema is also often identified. These lesions are best visualized on fluid-sensitive sequences, and any imaging plane may be utilized. Here, a subchondral cyst is identified in the acetabulum. An example of a subchondral cyst in the femoral head is identified in another patient. Labral tears are optimally identified on axial and coronal sections using fluid-sensitive sequences. An anterior superior labral tear is identified on this axial oblique PD-FS MRI. It is also well visualized on this coronal PD-TSE-FS MRI in the same patient. Capsular deficiency may be identified on MRI and can occur in the setting of a patient with a prior hip arthroscopy with inadequate capsular closure or without attempted capsular closure. These lesions can be clinically associated with hip microinstability, although gross instability has also been reported. Non-contrast MRI as well as MR arthrography may be utilized to assess capsular integrity. Here is an example of a capsular defect identified on an MR arthrogram. Tendinopathy is often identified clinically in patients with FAI. MRI allows assessment of involved structures and the degree of tendinopathy. The rectus femoris, iliopsoas, hamstrings, or gluteus medius may be involved. Here, the PD-TSE-FS coronal MRI of a female runner with FAI as well as severe hamstring tendinopathy is shown. This finding is also demonstrated on this T2-TSE axial MRI in the same patient. This article and associated technique video are intended to improve the clinician's ability to interpret hip MR imaging as well as review the imaging with their patients. It is important to also review the interpreting radiologist's report, as well as consult with the radiologist with any questions or uncertain findings.